it to go higher, that's for sure.
Exactly.
Oh,
Good morning, good afternoon, everybody. Thanks for joining us today. I really appreciate the time joining us. So I want to welcome everybody to webinar that's put on here by Digitsole Pro with in collaboration with Henry Schein on improving return to play and the prediction of ankle injuries with AI movement assessment technology. And so the star of the show today is Dr. Christopher Proulx. So Chris is practicing DC, also AT, and has many other initials behind his name. So without spending any more time in that, why don't we jump right into the content? So Chris, I'll turn it over to you. Again, thanks everybody for your time. A couple things actually I'm going to bring out. We just published a poll. If everybody could please just give us your response to your poll, it would be great. And second, if you have any questions or comments, please put them in the chat section or the question section, guys. We'll happily address those towards the end of the session. Okay, Chris, over to you.
All right, cool. Thank you, Brandon. I think I did the poll thing right. I'm also the one who creates the titles, which are all obviously a mouthful most of the time.
The poll is looking good. It looks like it's out there. So.
Okay, cool. Awesome. Yeah. So again, thank you all for joining us. Good morning, afternoon, evening, depending on where you are. As Brandon said, so my name is Chris Proulx. So I'm the Director of Education for Digitsole. I'm also in private practice. I've been a clinician for a little over 25 years now. Used to be a practicing ATC, usually alongside my academic appointments. So that's kind of the direction I'm coming from. I'm going to sprinkle a little bit of that as we go in and out and kind of get into some of the history. I'm even going to show you a poll that I had done on LinkedIn, which kind of prompted some of these discussions. So without further ado, I'm going to share my screen. Hold on, it does this little enter the matrix thing at first, but so I'm going to go to the here we go. All right, let's pull that up right here. February 7th. Oh my, I got that date wrong. So what we're looking at is return to play, prediction of injuries, and I've written a bunch of different things on this, and so what I thought would be kind of cool is to sort of lay out some of this like AI movement assessment, which stands for artificial intelligence, and we chose the topic ankle injuries just because they're so evident and prominent in many different areas, from regular life to obviously sporting activities, pretty much regardless of any group that you might work with at really sort of any level. I'll run through some statistics as we move forward, but like even in everyday activities of the general population, there's a really high incidence of ankle injuries. And so it's extremely well known. It causes enough problems that we have to deal with it. I know, we like to talk about ACL a lot, and as we should. But if there's 100,000 ACL surgeries per year done in the United States, for example, we can multifold that related to the ankle injuries, and not to say that it overshadows the ACL by any means in terms of the cost or the implications. And so I do a little bit of overlap, and one of the reasons is the other cool thing about talking about the ankle is its actual impact on what's going on in the knee, specifically with regards to non-contact injuries. The BOC requires this disclaimer, and this is for your protection as well, because you can qualify this as one CEU for category D. So that's category D. And so I am an employee of manufacturer. I'm not pushing any specific products, really just concepts of hopefully some things that might might pique your interest, maybe even explain a thing or two if you're a little bit unfamiliar with what some of this stuff can do. So nothing in here is meant to be a promotion for a specific product, and you won't hear me push any specific product. Like I said, mostly just the concepts and really about the education. So it's got nothing to do with them. Key points: using data to better inform the decision making process. Man, we talk about that a lot lately. I'll get into that and even some of the history associated with that. The
Yeah.
evolution, so following this process, and then looking at the environmental evaluation of performance. And sounds like someone's got their microphone on, and if Brandon, you can reach out to whoever that might be, or block everyone's, then that'd be helpful. Then I don't have to stop. Um, so the environmental factor is kind of new, mostly because I come from a laboratory environment where we collected tons of data. And one of the things we tried to do, and I was very fortunate to work with a gentleman by the name of Michael Stone. He was my mentor, friend for my master's and PhD. He was my advisor, and taught me a lot. So my interest actually initially in the whole data was in exercise science and sports science in particular for research purposes. And he tells an interesting story when he went to um, another university after he left, where we were together at Appalachian State University. And he was head of that department of sports science, and approached the athletics group and said, listen, would love to work with you guys. And was met with some interesting responses, one of which was like, well, that's all fine and good, yeah, you will be able to do some research, but the problem that we've always run into is collecting data. We analyze it and then eventually, publish a paper or something like that. And that could be, a year, maybe a longer process versus to what we know today in terms of sports science and collecting some of this data. It's got to be useful. It's got to have a really quick turnaround time effect. So, and probably even almost immediate for some of the things that we're talking about today. On that flip side too, like there's so much data available to us that it's sometimes challenging to figure out what stuff is going to be most applicable. So some of that is going to relate to maybe your specific environment. Again, this isn't about ACL, but if we look at the majority of 50% of ACL injuries occurring at that teenage level between the ages of 15 and 19, that's the high school sports medicine specialist, the athletic trainer, and the physical therapist that are working with those particular groups of people. And so, the kind of data that you might collect might be a little bit different than if you're working in a professional or that D1 program. Sports science, there's a new certification in sports science by the National Strength and Conditioning Association. Actually, Mike Stone wrote a very interesting forward if you get the textbook for that. But if you want to learn, a lot more about data and statistics, it's a pretty cool way to go, because you get a really high level certification from a high level organization, and it really kind of brings all that down. Like another person who is influential in a lot of the stuff that I do today in comparison, is able to, again, because of the relationship with Mike Stone, and see like the work that Dr. Sands was doing. And he's written some amazing papers, that may complicate it for some, but I think it brings it down to a level. It's like, there's a lot of data out there, and you need to figure out, what is going to be most meaningful. And this is a sports technologist from the USOC. Data alone cannot tell the coaches everything they need to know, about the athlete's future. So some of it, is sort of immediate, but even then we can go collect data. And to quote another former colleague of mine, Dr. Jardine, who taught statistics, and we were in a university group together, and everyone was talking about, oh, we should collect this, we should collect this, we should look at that, we should look at that. And he's like, you need to know what you're going to be doing with that data before you just pull it out, because it influences sort of the way you look at that, right? So if you come from any research background, that we needed to start with a hypothesis, because if we didn't, it might influence the potential of an error, when it comes to that. And it's a little bit different than the approach that we're looking at today in terms of sports science, but it stems from the same process in that, if you're calculating, volume loads, for example, in your athletes, that comes from data that came from a specific research projects that, develop some of those standardizations. Let's add to this the AI factor. Like, this to me is going to be a bit of a game changer, but everyone, I won't say there's a freak out lately, but it's a huge topic right now because of what we're capable of doing with it, for good and bad. My wife is also in education. She's a teacher, and so we're looking at using things like Chat GPT, and how, we need to be able to manage that. There are countries and, continents that are basically outlawing that because of the lack of regulation and the potential, negative impact. Even here in the United States, the influence that we saw with, Google might have on a political race campaign, for example, that may that could grow even bigger with something like Chat GPT. So that's like that form of artificial intelligence. That's why I call it sort of the elephant in the room, because I'm going to show you a poll here in a moment, and we talk a little bit about, what that meant in terms of the information that we gathered from that. It was just a one question poll, and I don't know, maybe some of you even saw it or participated in it, but like, it's not really meant to be this bad thing. And like anything else, it's something that we need to figure out and determine a little bit more. It's not new. A lot of people just, they're hearing about AI, and they just hear it sort of on the sideline. And now, with Chat GPT, it's become, at the forefront, and, some people are a little bit concerned with it. But AI has been part of, healthcare for quite some time now. And even if we look at its implications, one of the things that it's done, and I use the example in imaging studies. And so, within a first year of it being implemented into a program, it improved the diagnosis of breast cancer by 11%. And that's huge. It improved it. It didn't replace, who was already there. There were some predictions even 10 years ago that AI was going to replace a bunch of us in like healthcare or in some other fields. And, you know, like the transition from assembly lines to robotics, I mean, yeah, there probably is going to be some of that, but more so, hopefully, a translation or a transition into some of these other areas. But in general, if you're not familiar with it, artificial intelligence is like regular intelligence. So, for example, right now you have someone that, may walk into the clinic, um, and complain of a certain condition. And so what you have to do is go through, sort of that algorithm process to determine what tests you're going to be performing, the history that you're going to be taking. You aggregate all of that data, and then you need to come up with a diagnosis or a set of differential diagnosis. And then along with that, what does your plan look like? What does your care plan look like? And one can argue that it starts even before that, right? Because in athletic training, like that group in particular is some of the best at collecting like baseline data, right? And been using it for years. Even when I was a student, that's just what we did at the beginning of every season, and obviously that continues today. And that's kind of unique, even a bit unusual, as we see in other healthcare practitioners. I mean, if you go to the physical therapist, the typical chiropractor, if they're not involved with that sport team, they get someone after they've been injured, so they don't have baseline data to go by per se. So that's something that's really unique, and it's a really wonderful opportunity, to move that forward in terms of that prediction process. Because in general, in healthcare, early prediction has been shown to reduce the progression of certain disease processes, or at least minimize it, let alone, reduce the overall healthcare cost. So artificial intelligence is basically, it's using embedded, computer algorithms and programs very similar to the way that a human, sort of thinks, but, removing that human-like aspect of, being distracted or not knowing a certain component if you had to do some mathematics, or all of those things that we may not know. So, for example, even when you look at something like ChatGPT, what it does is, or I should say, in its development, it's this amazing multi-million neural network, and it's again kind of like a human brain in the way that it reaches out and gathers some things. There's also a lot of limitations to it, so that's why, at least right now, it's not going to eliminate that. And as I always say, focus on what makes us skilled or most important. Or as I joke, my wife says, her definition, artificial intelligence, is thinking you won an argument. Because I never do. But anyway, so this was something that I had posted on one of the groups in LinkedIn, and it's a little different. It's not directly related to what we're talking about, but in a sense it is, because we use a lot of similar information, especially when we're going for that return to play aspect when it comes to the predictability nature, and in that, it's part of the assessment, and we use assessments also to influence the intervention process. So, do you believe AI backed human motion technology can improve patient compliance and their outcomes in rehab programs? Half the people said yes. A quarter of the people still are not sure, and almost a quarter of the people emphatically said no. I mean, this wasn't really deep into that, but I think it kind of outlines that probably at least half of the people may not have a complete understanding. So, for example, the people that said no, it already has. So it's been proven. And then the people that say not sure, then we'll have to figure that out. One person had commented, it may improve outcomes by demonstrating to a patient whether they are, I think, properly performing their program, but it would be difficult to use to improve compliance. And again, that's already kind of been out there. So adherence and compliance are, sort of two different things. The adherence aspect is, I went and I bought my medication, or better yet, I signed up at Planet Fitness and I have a membership. Compliance is, do I actually go? And what happens is, eventually there is overlap, because without compliance, adherence usually typically is going to drop off, because they don't see the value in continuing that adherence, program. And there's been some interesting, approaches to some of this. We know that constant touching and reaching out to those constituencies, like our patients, does actually improve that. And that's the benefit of technology, is you can send someone a text, and it actually has been shown to be influential at improving their compliance as well as their adherence. I think it was about 10, 15 years ago, France, the country of France, was the pharmaceutical industry was attempting to implement a compliance program, government program, in taking medication. That may have a bit of a double-edged sword, because I mean, those things are not laws, but data today actually shows us that um, compliance programs are hugely important. Now, we better make sure that it's the right one. We're very quick to maybe implement certain things that might not be the best choice for the patients. But what we know today still is, and this is an example of leading the horse to water and not being able to get it to drink. So, maybe I'll take a swig at that. But so it actually has already been shown to be influential to some degree in terms of what we can accomplish. And that's just not AI stuff. That's data in general, right? That's one of the things that we use. To throw out some statistics in outpatient physical therapy, WebPT's done a great job at gathering some of this information, but like 28% of outpatient physical therapy patients discharge themselves within the first 3 visits. Only 30% of outpatient physical therapy patients actually complete their course of care, which leaves a bunch of things on the table. One of which is not getting complete and full recovery. Right, in sports, you have a bit of a captive audience if you're an athletic trainer in particular, where we often had a little bit more control. Like, you don't get return to play until I discharge you and clear you for that process. So, can we predict injuries or re-injury, especially when we're thinking about that return to play? Right, the return to play aspect has two components to it. Is we want to make sure that they're back to where they were, right? And the reason for that, one is performance, and the other one is to make sure that they don't re-injury that process, that thing that happened to them before. Again, that statistics in ACL injuries in that younger group. So that younger group, the 15 to 18-year-olds, has the highest percentage of the ACL injuries, and then they also have the highest percentage of reoccurrence, which to me is not surprising. But why is that? And I'll show you this call to action sort of at the end. So the prediction aspect comes from we need to have something that sort of proves that, and we use standards. It's a multi-step process to create some measures and effectively be able to implement those measures. And especially what I'm really focusing on today are some of these field tests, performance-based outcome measures that initially began as field tests because not everyone, we didn't always have all this data that we have today. And even again, that we have this data, well, what exactly is it good for? So there needs to be some standardization and there needs to be some, validity and reliability to what it is that we're looking at. So baseline testing, it's not 100% unique to the athletic training setting, specifically at the college and the professional level. You'll see some of it at the high school level, but it happens there a lot more than what we see in the other areas of conservative medicine approaches or sports medicine in general. Baseline testing, it's also not synonymous with just things like that. If you go in and you have your yearly checkup and they measure, do blood chemistries and check your vital signs, that's a form of baseline testing. It's looking at your performance measure relative to what that average should be and where you are at that particular moment in time. Where benchmarking, um, we may take benchmarking sort of throughout. So oftentimes, the baseline testing, um, it gives us that certain moment in time, and then we don't quote unquote, baseline test again till the beginning of another season. So often, hence the term baseline testing versus benchmarking. We're going to use that often to figure out where someone is relative to another group, right? So, for example, when I do vertical jump testing, then I can actually match that person's performance relative to other people of that gender, that age, that specific, sporting category, or something like that. And then from there, we can actually use that to develop that target to say, okay, so this dude wants to be a professional baseball player playing shortstop. We have data that looks at, what a shortstop looks like in that level, match that up against, and we can create targets and say, 90% of them have a vertical jump of, at least 22 inches, and you're only at 19. So our target is going to be something like 19. Or we can use it in what a lot of people are doing today, which is looking at volume load and uh, and that volume load related to player load in terms of the level of intensity that they're getting to within practice sessions, game sessions, and things like that. And so we don't want to go beyond that because we have standards or statistics that tells us that that's going to be a potential problem. And then even then, we may be a tweener because here's the thing: is we want to do what we can to maximize however many training days and practice days that we have, but we can't overdo it. And I mentioned Bill Sands a little bit earlier. So Bill Sands was responsible for implementing the first recovery center at the USOC in Colorado Springs in 2008. And basically, the first time he presented the data at the symposium at ETSU, East Tennessee State University, where Mike Stone is, and Meg Stone. Um, Basically, it was kind of this free for all where again they were collecting a bunch of data, but they didn't have anything to create some standards and match it up against. And then when he presented the data, a lot of things just didn't seem to really matter. Although there was one cool thing that always stuck out to me was there was an inverse relationship between the number of massages that the athletes acquired and gold medals won. So take that for what it's worth. But the reason for this implementation was because if we can recover more quickly, and if you're a high level athlete and you can gain 2 more weeks, 14 days of intense bout of training, what does that potentially look like, right? Because it's a fraction of a percentage point that differentiates a gold medal winner and even the person that came in fourth place in a 100-meter sprint, right? And then the normative data, and this is where this AI kind of comes into place. Is like, man, lots of data, lots of things to look at. Well, the AI aspect of things allows us to make these decisions and the turnaround times much more quickly versus, when I started this journey 25 something years ago, when even our emotion analysis, I was click, 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 points frame by frame, and at 60 frames a second. Yes, it's a lot of frames, and so we were very very rigid in terms of the amount of motion analysis that we would capture, because if we were grad students, we knew that's how long we were going to have to spend in the lab. So, related to that baseline, if you don't have baseline testing, is it even useful to you to be able to collect data? Like, can we still use some of this information? And the answer is yes. So, we have research that shows that using normative based, right, even if you don't have the baseline testing to know where that person was, we still have at least a decent enough amount of supportive evidence that says that we can use the normative data to sort of establish that. And again, that's not a new concept that we have in healthcare, and we can even do that with biomechanical measures, at least certain measures, right? And so the classic example is using these hop tests or jump tests that often were utilized for return to play following a lower extremity injury. Specifically, originally was that ACL is just saying, okay, the norm on that would be, greater than 10% means that they fail, right? So the norm is less than 10%. So we could use that criteria because that actually then matched it up against that individual person to say that, well, if one leg's a bum leg and the other leg's supposed to be the good leg, then if you match up the bum leg, then therefore it should be pretty close to what that should be, in terms of their capacity. So we can actually take that a step further too, and I'm going to show you that we can take some of what used to be these field tests and now break down the surrogate components to it. And hopefully what I'll show you is, the research out there emphatically, I shouldn't, you should never say emphatically, a large body of it shows that the best tests for these processes are these more functional related tests, because they're associated more with a little bit of translation to what we're actually doing in sport. So I already kind of mentioned this, why ankle injuries, because there's a lot of them, and it's quite evident, and it's often major reasons that people are going to be on injured reserve. Some sports are a little bit higher than others, and like I said, even the general population, um, and we see over 2 million ankle sprains treated annually in the Western countries, and then the incidence is even higher, in sport activity. And though again, there are going to be some athletes more so predisposed to ankle injuries than others. We obviously see a lot in soccer, football, not quite as many in skiing. So there are going to be some differences in terms of how the athletes actually function, and you know the opportunity to have contact versus non-contact as well. And then we look at the chronic. So there's the acute aspect. Oftentimes we know exactly what's going on. We saw the mechanism of injury, especially if it was a contact unpredictable. We didn't know, and so maybe we couldn't predict that. But what we do need to do going forward is we need to make sure that they don't succumb to becoming a chronic injury. Then we start to get into some predictive values, one of which is return to play after they've had the acute, and then making sure that they don't get into the situation where they become that chronic person. So approximately 20% of of acute ankle sprains develop into chronic. And if acute ankle sprains is a really really high list, then so is that 20%. That's a lot of people that succumb to chronic ankle instability issues. Okay. And here's the problem associated with that is it's not just going to be the ankle. We're also looking at the knee. So even doing something very simple as a gait analysis, a walking analysis and or running analysis, we see that chronic ankle instability patients, they have decreased knee flexion. And decreased knee flexion is associated with what we all know is going to be a non-contact knee injury, right? And so, gosh, especially important when we're looking at some of these younger folks. And then, of course, we all know what happens to a lot of these injuries as people tend to age. The other thing I want to, highly point out is looking at that proprioceptive impact. I'm going to show you something here in a second that might be of interest to you, maybe not, but to know that, that's where we get back into looking at sort of these implementation aspects of functional versus more of these surrogate measures. For example, a lot of studies have shown that quadricep strength alone is not really going to be a good predictor of return to play following ACL reconstructive procedures. It's actually more of the functionality to it, right? And so it could be their ability to produce force or power, right? So rate of force development, which is going to be hugely important with regards to that landing aspect. Implementation, is it worth it? So when I think back when I first opened my private practice, which I opened simultaneously working at at the college level, I think about how much it cost me and my investment into that, and then I think about some of the stuff. And sometimes you can see the stuff behind me is what that may cost today, and like holy cow, it is different. But when we look at and not to call any Major League Baseball team out, but I was down at spring training one year, and it was just several months after they won the World Series, and we're talking about an implementation, a lot of great data, statistics on the efficacy and the outcomes, and the head athletic trainer going, yeah, I don't think we have the budget. um it probably wasn't the budget being a Major League Baseball team and having just won the World Series, but it's that value proposition. And I get it. There's nothing wrong with that. I think that's our knee-jerk reaction to it. This was an interesting study looking at when you implement something to reduce injuries, what exactly does that translate into? Um, and so this was an interesting, conglomeration of data. So they used technology, they used motion capture utilizing force platform, and specifically they said that they were calling out, kinematics. Obviously, they can do kinetics on that as well. But what was interesting when you look at some of this data, just overall users versus non-users, I mean, you saved an extra $500,000 in that category of the users of this particular implementation process, and so that's pretty interesting. And then we also saw a dramatic, not only a reduction in the group that were the users, but an increase in the group that were non-users. And this study's not that old, and so when we evaluate, what are some of the other things that was going on? It was the same groups. So you would think that the implementation programs, rehabilitation, typically the other assessment tools that were being utilized hadn't changed dramatically, just over that very very short time frame. And so the price alone is gigantic in terms of what you can actually. So when I discuss this with people, I'm like, this is the kind of data you need to go back to, and it might be different, it might be even more or potentially less, but let's think about even aside from the dollar sign associated just with the institution, if we did a better job at return to play of that 15 to 19-year-old age group, what does that look like in terms of just overall healthcare costs? Not necessarily what an institution pays for, but you know your specific community. And here's the thing too, is this is right at that given time. Like, what about the longitudinal aspect of the conditions that sort of formulated as a result of what happened to these injuries? What was the long-term effect? Because we know that there are those long-term effects. So quickly, I want to go over what are the tests that are used. Basically, they're performance-based outcome measures, and this is specifically, obviously, looking at the lower extremity with regards to the ankle injury. So one is performance-based outcome measures. So that's something that incorporates a movement pattern typically versus just looking at a knee extension, right? So things like your drop jumps and your single leg verticals, your double leg verticals, your triple hops, your single hops, and things like that. Why? Because it has more of a relationship to what we're actually doing functionally. Um, but here's, I think, what we're also finding as a result of looking at this is when these tests are done and evaluated, and what we're showing here in the reproducibility of utilizing this data is the specifics that it's generating at that more surrogate level, things that maybe some of us haven't been able to capture that I'm about to show you here in a moment. So um, the assessments that we're also getting down to are not just the performance-based outcome measures, but those specific details that otherwise we weren't capable of looking at. In other words, your impact forces upon landing, or the influence of your foot, its deviation effects as a result of your landing, right? So not just doing that drop jump, but where do we get more of that information, and how can I better tease it out? Because even if you do see that dynamic um, knee valgus position, it's associated with multiple factors. And so if we can do a better job at sort of figuring out exactly, what the problem is, then maybe we'll do a better job at minimizing that potential of injury and seeing even better outcomes. I use some examples here of running, and so I'll scoot through this pretty fast, but I use the example of running because, man, we don't like really have good data on predicting running related injuries. And we do know some of these things, right? A lot of the biomechanics change as you run faster. If you've previously had an injury, vertical loading rates seem to have some potential impact, especially if you've been injured and then you go back to running, and we figure that out. And the reason I'm using running as an example, other than just the fact that we don't have really good predictive measures, part of that is because a lot of them were field-based tests, and we didn't have a lot of good relationships, but really looking at long-term effects of alterations in kinetics and kinematics. And there seems to be some implementation implication to that, including the asymmetry effects. And the asymmetry, we looked at it in my lab from a performance perspective, and we found that influencing performance, it doesn't take a lot. An asymmetry greater than 6%, can have a negative influence on someone's ability to run even the 40-yard, for example. And certainly, where does that translate into with what? It actually had a lot to do with the acceleration aspect, right? Which, in that regard, that's the majority of what a lot of athletes do. Most of them aren't sprinting for 40 yards at any given clip all the time. It's more about that rapid acceleration effect. So we've got some implications to some of these prediction models. And let me give you a summary here. So previous injury is one of them. Volume. I don't think that's a surprise to people. It's an implication. I think we're getting better at it because we're doing better at measuring player loads and things like that. Increase intensity. I'm going to show you something here in a moment that what changes as a result of that. Things like asymmetry. Hip strength is potentially a big one that has a lot of influence on sort of where your center of mass ends up over those other structures, which can have an influence and an exacerbation, especially on some of those areas that otherwise um, may not seem to be as bad as if you didn't have that hip problem. So I won't get into a lot of mechanics. Whoopsie, I do want to show that. Just a quick plug that a lot of people will not think about some of these other performance measures, such as the walking. So walking and running actually have an extreme amount of overlap. And the walking analysis actually gives us a pretty cool amount of data because there's a lot of normative values to that. And that's again where the AI comes in, because I can do a gait analysis and actually tells me the degrees of asymmetry, but also post it against the normative values, whether or not it's going to be increased or decreased. And then certainly we can take that to the next level. So this is looking at an AI based platform. So there's a coloration here. Now we don't have a lot of normative data specifically with regards to running, but the whole symmetry aspect is pretty important. So this is taking the same person and just running them at about 8%, almost 9% difference in speed, and what we're able to tease out, because this person was like, I'm struggling at improving. And so when they try to run at a faster pace, we start to see that asymmetry. At 3%, not a big deal. And most people look at that and say, well, that's not a problem. Well, you need to increase the stress load. And when we increase the stress load by only 9%, we double the asymmetry. Some of these other characteristics would be normal. So I can actually look at contact impact forces. They typically go up as you run faster. But if you're actually trying to change someone's gait pattern, that's a great opportunity to have that data to look at. We see that, these two differences in the stride length, it's continuous. There's a 2-inch difference, which is not huge, but it continues as they run at that faster pace. And then some of the other things that we see is we start to see some of the angles change a little bit. So this is the angle of the foot on heel strike, because this person is heel striking. You can also get midfoot striking. But what I like about this is now I'm looking at, this is the right foot over here on the right, up in the top, that I'm circling right here. That's about a fairly normal trajectory that I should see through that stance phase in running. This isn't it. It almost mirrors that. So this person is supinating too far. They're not transitioning over onto that first and second ray, which can be really difficult to pick up if you're just looking at them, because we're looking at a difference of 15 to 10 degrees, which obviously that's a significant difference, but you can't pick that up with the naked eye. The other thing that we see here is, as I'm increasing the speed, is I really start to see the standard deviation increase. That's what the two thin lines on either side actually show us. I can also pick up and get some more specific details, and sometimes we see abnormalities. So this is just a moment in time, and the strike pattern eventually becomes very inconsistent. And it's the question is it a right leg problem or a left leg problem? And that's where having this data actually allows me to tease that out, because a lot of people think, oh, well, you're spending more time in ground contact on that right leg. Well, keep in mind that my right leg also had a longer stride length, right? It was only by 2 inches, but it had a longer stride length. One would think that if the increased ground contact time was the problem, it should have a shorter stride length. So this problem was actually on that left side, and it was because of what was going on with that contact. So this is a different one. This is the guy I'm going to show you here in a second. But if you look over here to the right, that's a much more normal. So they're going to heel strike on the outside of their foot. Then they transition into the midfoot position, and then they're going to roll over off to the toe, right? It's a little different than if you think about, pronation, supination at the forefoot, but the foot as a block model. This is a normal trajectory, even if you don't know what this means. And then you look at this guy over here. I want to draw your attention to the numbers. So the orientation of that midfoot heel is at negative 63 degrees, almost rolling on the lateral malleolus. I mean, and I'm going to show you the video, and you can't really see that. And actually, it was that young gentleman I just showed you the walking and the running of. And so here's why I'm showing you this comparison. So what we did is, often if I see some abnormalities on the running, I followed up with a jump test. And like I said, I like using the forward hop test, and there's some data that shows that it actually provides more relationship to overall function because of that forward translation. And so what we typically used to see was we used to just measure the distance. So this is 78 versus 66 inches, and it's a 16% asymmetry, which I wouldn't have thought that, but I tested them anyway. And that's why I didn't just do a single leg vertical jump. So what do we got? We've got a 16% difference. And some people would look at that and say, well, yep, that kid shouldn't be playing. He was very, very high level. It was his senior year. Um, and so this is what we got. And someone would look at this real quick. If all they had was the distance symmetry, then they would say that this is problematic. And I'm still not saying it's not problematic, but let's look a little bit deeper here. So with this data, with this ability to have, today's AI technology, it also shows me the height. So now I've got some information looking at that trajectory. Because you look at his flight time, 381 versus 388, he actually spends more time in the air on that right, even though he jumped not as far, which is interesting. It was a trajectory thing. It actually has a little bit to do sort of with his technique. This is something new, contact stability. So what we get here is upon initial contact, we get the foot orientation relative to the ground. And within the first 250 milliseconds, the amount of translation, right? So you don't want to see a lot of correction because that means that they're not landing appropriately. And then we can see how fast they got into that. So what we do notice on that left side is it's double that compared to the right. I can't get into all of that just for the sake of time, but even if you know that, try to look at the symmetry aspect between the right and the left. Also, here's something of interest. Now, what you tend to see in a vertical jump is um, approximately somewhere between 45 and 55 degrees of plantar flexion, this flexion angle at takeoff. On that left, so this is going horizontal. We should see closer over typically 75 degrees. He's at 82 on the left. He's only at 67 on the right. So it definitely has something to do with his technique. What's also interesting, we look at rotation around the z-axis, and that rotation around the z-axis, this is his foot progression angle, the amount of toe out effect, right? This has a direct relationship to the dynamic knee valgus. But even better is I'm able to look at this in that single hop. I look at this in the triple hop as well. And now I get some really good information based on that deceleration effect. Like when I was training young athletes that I want you to be able to slow down within 3 steps, for example, and hold that position. Then we work up into changing direction. So their position is hugely important with regards to how they finish that last step before they actually change. So this is the triple hop, right? It's very similar, except there's 3 hops, obviously. But here's what's different about the triple hop is now we get ground contact time. So ground contact time is awesome because I want to see what his ability to load and explode looks like, right? Because a lot of those single tests, they're great, for that measure, but can they repeat that? Because that's much more related and functional. So historically, we've only been able to look at the distance. Well, he tightened up this distance, so now he's only at a 9% asymmetry. He's still 228 inches on the left and 207 on the right. Well, let's look up here. His stance time is 402 milliseconds on the right. In between those hops, 371. So if you know anything about the triple hop, they're supposed to do this vigorously, right? They're supposed to land and take off as quickly as possible. So part of their ability to be able to take off and move rapidly is they should be able to control the landing. And so we see that, he has longer contact time on this side than he does on the other side. Well, that actually also has something to do with the ground reaction forces and the peak forces if we were to measure that during that takeoff. So we still see his left, he's right foot dominant too, which is interesting. His left seems to exceed in the performance. So now the 30-second side hop test. This is where it gets, I think, pretty interesting. So let's look at his flexion angle. I'll show you a video. I didn't want to, spoil here, but so the side hop is that 30-second side hop, and you're 40 centimeters apart, just about 15 inches or so. The reason I also like the side hop is it shows me their evolution over the course of that 30 seconds. And so, can they hold that pattern? Can they hold that cadence over that? Or are they pooping out? Now, if they're a thrower, they don't do anything for 30 seconds. And so I might be okay with that. And so if I started to see some degradation, near the end, but this guy does get involved in some plays longer than that. He also plays lacrosse and is a multi-sport athlete. So the flexion angle at takeoff. Now it shouldn't be as high because you're going from side to side, but we do see he's higher on that left side than he is on the right. We also see his jump height is a little bit higher on that side. But then you look at his rotation around the z-axis. His average landing, he's slightly toed in. So think about this for a second. He's landing slightly toed in a more plantar flex position. And that might, ring some bells. And so think back to his heel landing position when he was running and what that looked like. The other thing that we can look at is his flexion angle at landing as well. And we see it's 5 degrees higher on that left. So he's in a lot more plantar flexion on landing and takeoff. So this is that same young man. So I was just taking some video to show this wasn't the full 30 seconds, but that's actually the normal distance. Yep. Um, and as you can see here, he had a bit of a landing problem, and I don't have time to get into the full mechanics of all of this. But what's interesting is if you watched it really closely, and I could slow-mo it for you, but what happens is after he lands, you'll notice that you should be in peak knee flexion, peak hip flexion. His shoulders come into full rest position. The reason you know he's going back up is because now the angle at the knee and the hip are increasing and his shoulders are actually elevating. And that's actually what the heck, I'll play it again real quick. And that's actually what's happening when he goes into that landing. And I'll try and stop it right here. Oops, that didn't work. I don't have the right player on that. So what happens is he starts elevating his shoulders. He's extending at the knee and the hip, but his ankle is continuing to go downwards, right? He continues to go into an inversion position. And it's hard to see it's a little bit slow motion, but you can kind of pick up on that. Okay. Here's why I like ground contact time. One, just because of my history and background of looking at that. But these are such minute times that we can't pick this up with the naked eye. And that's why a lot of our data is actually showing us that these ground contact times provide us with a whole lot of information. I mentioned this earlier. This is sort of the call of action. So this was an editorial published in the International Journal of Sports Physical Therapy. And what they're saying is, man, we need to do a better job at really looking at the return to play. What's different at that 15 to 19-year-old? Yes, they're younger. They probably don't have the same availability to what maybe that high level athlete certainly gets. Their overall training and conditioning, right? So I think we all know that the role at these different levels is a little bit different. So they don't get as much attention, but what we probably need to do is make sure that we spend a little bit more time in that overall return to play aspect. And it doesn't have to take a lot of time. The hugest benefit of the artificial intelligence implementation in today's technology for movement analysis is it decreases time dramatically. I could do a full battery of tests and have all that data that I just showed, in literally just a matter of minutes. I can do a walking analysis in about 30 seconds, have the data ready, and analyze that in about 2 minutes. So we know that we can actually use a lot of these same tests as predictive. So obviously the return to play, the nice thing is many of us already know these, so we can implement some things that we're already doing. We seem to see that these differences in variabilities with regards to symmetry and standard deviation are really good predictors of abnormalities, which again, really difficult to see, without using some technology as I mentioned already, ground reaction forces and foot orientation also have not only what's going on the foot, but a dramatic influence of what we also see at what potentially is going on in the knee. So a couple minutes to spare. I hope to be done a little bit sooner, but anyway, we've got a couple moments for some questions. Email us at education@digitsole.com if you're looking for a certificate of attendance, because you'll need that if you want to submit it to the BOC. So special thanks to you all for listening to me talk. I feel like I have one of the coolest jobs in the world. Thank you, Brandon. So I get to, I talk for a living. And special thanks also to Eric Kearns and his whole crew over at Henry Schein, because without them, a lot of this is very challenging to get the numbers. So again, thanks to all of you.
Absolutely. Yes, Chris, thanks. Really great content. And again, thank you everybody who attended. As Chris had mentioned, if you're needing a certificate for any reason, please email us and we'll happily get you on. It's just education@digitsole.com. And then Chris popped up his email. You got questions, guys, please feel free to reach out to him as well. But look, I mean, cool tech, and hopefully, look forward to discussing it with you more. If there's any questions, obviously Eric Kearns over at Schein and his team can definitely help out as well. So before we depart, guys, I'm just looking to see in the chat, any questions from anybody? Okay, feel free to put it in the chat if you do. Thank you, Gail. I agree.
Also, like, I don't know, any of you that might want the information from the slides, feel free just to shoot us a message, and I'll put those into a PDF. Unless you want the full Monty, the whole PowerPoint, maybe you're teaching a class or something, and these might be somewhat useful or something like that. So yes, education@digitsole.com. And yeah, I think that's about it. Hopefully everyone's winding down. It's finishing off in college, university, and high school's coming to a close very soon. And hope you all get some downtime and have a great summer if you get your summers off.
Yeah, absolutely. And one last thing, guys, just quick. You can go back and view the video of this on the link. So it will have video replay access. And then inevitably, guys, we do also upload these on our YouTube channel. So if you get a chance, check out YouTube. It'll be up. It'll take a couple days to get over there, but we will get it up on YouTube as well. So feel free, guys. And if you liked this talk, Chris has got a lot of his other webinars and talks on YouTube. So again, check out our YouTube channel. It's just Digitsole YouTube channel, and go from there. Okay. Awesome. Thank you everybody for your time. Really appreciate it. Have a fantastic day, and
awesome.
We'll be in touch.
1 o'clock. Bam.
On the money. That's how you do it. Take care.
Not very often.
That's right. Have a good one now. Bye.